Good morning. Can we put up that one slide, please? No, the one, yeah, that's the one. So, good morning. I have one message and one message only from the BJUI to BAUS, and it relates to a rather disappointing story. One of my associates was asked to write the main editorial for the BJUI, and the first line of it said, in the EAU guidelines, and the second line of it said, in the AUA guidelines, and it went on, and et cetera, et cetera. Don't laugh, it's the truth. So I pinged him an email saying, do you know that the BJUI publishes the NICE guidelines? How many of you in this room knew that the BJUI publishes the NICE guidelines? Thank you. 50%, that's good enough. These are the best guidelines in the world for three reasons. Firstly, they show clinical effectiveness. Second, they show cost effectiveness. None of the other guidelines do that. And third, and most importantly, they are not conflicted. No conflicts of interest. I present it to you here today as the BAUS membership and the international membership, just to know that we have the best guidelines in the BJUI. Please read them, and please cite them. Thank you. You may smile. Which brings me to the John Blandy Prize. Francesca Pisano belongs to the department of my good friend, Paolo Gontero from Italy. This is a multi-center study on bladder cancer. And to tell you more about it and receive the prestigious John Blandy Prize, I give you Francesca Pisano. Francesca, come on up. There has to be an official photograph. You're supposed to hold this. Got it?
Thank you.
Congratulations.
Thank you very much. Dear colleagues, good morning, everybody. I would like to thank you, BJU International and the British Association of Urologists, to give me this great opportunity to be there today. I would like to talk to you about the role of transurethral resection in the management of high-risk non-muscle invasive bladder cancer. As we know, transurethral resection of bladder tumor represents the first diagnostic and therapeutic approach for non-muscle invasive bladder cancer. Currently, a re-TUR within 2 and 6 weeks after the first resection is performed in the most of the cases of non-muscle invasive bladder cancer with high risk of recurrence and progression. And the goal of this second resection is to avoid the presence of persistent disease and to reduce the risk of substaging. But why we need a re-TUR to ensure we are not leaving residual tumor or substaging the tumor? There is a nice study published many years ago in the BJU. In this study, the authors perform a first complete TUR and then perform a biopsy in the bed of the resection. As we can see, they found a high percentage of residual disease that reached 36% in patients with T1 disease at TUR. Currently, there is an open debate on the risk of residual disease at re-TUR. Here we can see a nice study published by the group of AIR. In the table, we can see the pathology at re-TUR. So the author says that even in the presence of muscle at first TUR, there is a 75% of residual disease at second TUR for T1 patient, so a very high percentage. This is a randomized clinical trial published a few years ago in the European Urology. Here we can see data about 210 patients with a diagnosis of T1 tumors. These patients were randomized into 2 groups according to re-TUR was performed or was not. And in this case, even after a complete first UR, a residual tumor was found in the 33% at second UR. Moreover, we can see in the Kaplan-Meier that patient with the second RIT-UR had a better progression-free survival if compared with patient with no RIT-UR. That means that RIT-UR could really affect the prognosis of this group of patients. What can we say about the risk of upstaging at RIT-UR? Here we can see another study from the group of her, about 150 patients with primary or recurrent tumor that underwent a RIT-UR. In this case, we have a 79% of residual tumor, and 29% of the patients were upstaged to muscle-invasive bladder cancer at second RIT-UR. Moreover, seems that the pathology at RIT-UR can change the tumor treatment in this series in the 33% of the patient. So authors concluded that routine repeat resection is advised to control the non-muscle invasive bladder cancer and to detect residual tumor. Even if a part of the literature shows such high percentage of residual disease and upstage to muscle invasive, here we can see another recent series published from the group of Palou. Here we can see 210 patients with a diagnosis of T1G3 tumor. In this population, 62% receive a RIT-UR. Here we can see a quite low percentage of upstage to muscle invasive disease that is about 7.4%. In this population, moreover, RIT-UR reduced the 3 months recurrence rate and the progression rate during the first year. By the way, if we look at the Kaplan-Meier, we can see that RIT-UR was not able to improve the outcomes, in particular was not able to improve the progression rate, the long-term progression rate, and the cancer-specific survival in this group of patients. To conclude, we can see here a nice review published on the role of transurethral resection in non-muscle invasive bladder cancer, and we can see that according to the available literature, in case of T1 tumors at TUR, we can have a residual tumor of 51%, ranging from 20 to 71%, and the risk of upstage among 80%. I would like to talk about the risk, the importance of the pathology at RIT-UR. Could the pathology at RIT-UR influence the prognosis of this group of patients? Well, it seems to be yes. Look at this paper published by her a few years ago. Here we can see the results about 710 patients with Ta/T1 tumors who underwent a RIT-UR. In this case, 76% of patients with T1 and RIT-UR progressed rapidly regardless of the stage of first RIT-UR, meaning that the stage at the second UR is probably more important than the stage at the first UR. Let's talk about the guidelines. I would like to talk just 1 second about EAU guideline that says that in case of non-muscle invasive bladder cancer, we had to perform a retour when the first tour was incomplete, if there is no muscle in the specimen of the first UR, and in all cases of T1 tumor. But there is no more indication to perform always a second UR in case of high-grade tumors. In this table, we can see that there is a quite good concordance among all the most important guideline panels, but there is still an open debate about the role of TUR in high-grade non-T1 tumors. In this framework, we performed our study. The aim of this study was to determine if the RIT-UR in the presence or absence of muscle at first UR in patients with T1 high-grade disease makes a difference in terms of recurrence, progression, and cancer-specific survival. We included in the study patients with a histologically confirmed diagnosis of T1 high-grade tumor and with at least a full induction course of BCG as their initial treatment for the T1 high-grade disease. We did not include patients who previously received BCG for a tumor that was not T1 high-grade, patients who did not receive a BCG as the first treatment for the T1 high-grade disease, and patients with a history of upper tract tumors or T2 tumors. Patients were divided into 4 groups, as we can see here, according to the presence or absence of muscle at first UR and whether or not a RIT-UR was done. We conducted a retrospective data collection. We received data from 24 centers around Europe and United States. And the Cox regression analysis was performed in order to evaluate the impact of most important prognostic factor on recurrence, progression, and cancer-specific survival. We collected data among 2,451 patients, of whom 935 underwent a RET-UR. Muscle at first UR was present in 30.5% of the patients, and the 66% of the patients with no muscle at first UR underwent a RET-UR. Here we can see the baseline patient characteristics according to the 4 groups. Multiple tumors were more likely to undergo a RET-UR when no muscle was present in primary TUR. Persistent disease at RET-UR was documented in 65% and 85% of patients according to the presence or absence of muscle at first UR, and the rate of persistent T1 disease was higher when no muscle was reported at first UR, reaching at 40%. Our median follow-up was about 5 years. Here we can see that we have a recurrence rate of 51%, a global progression rate of 19%, and the cancer-specific mortality of 9%. In this table, we can see that the worst prognosis has been observed in patients with no muscle at first UR and no RET-UR. In this group, we can reach a recurrence rate of 60%, a progression rate of 21.5%, and the cancer-specific mortality of 11%. Here we can see the univariable and multivariable analysis. In our study, in our population, the multivariable analysis says that RET-UR had a borderline positive effect on outcomes only when muscle was not present at first UR. In conclusion, we can say, according to our result, that RET-UR had a positive impact on recurrence, progression, and cancer-specific survival only when muscle is not present in primary TUR specimen. Moreover, RET-UR may be avoided in patients with T1 grade disease where the first UR was deep enough to include muscle in the specimen. Our study, our result, has some positive implication. First of all, a positive impact on the burden of healthcare costs of bladder cancer, and moreover, a reduction in exposure of the patient to the risk of additional surgery. Thank you.
We've got time for some questions if you're happy to take those, Francesca. Yes, please.
One of the challenges I've always found is the timing of BCG. If you literally take the re-resection to be within 2 to 6 weeks, then I don't see how you can give induction BCG before you do a repeat TURBT. But I see in your study the inclusion was that they had received that. So clearly they're not getting a repeat within 2 to 6 weeks. They're getting it within 3 months or something of that nature. Can you comment on that?
The only thing I can say that you are right. Unfortunately, since this is a retrospective data collection, we are not able to ensure the time of starting BCG. But I can say that all the patients, I suppose, they receive patient who receive a RET-UR before the start of induction BCG, even if it means a delay in starting the therapy.
Francesca, this was amazing data from so many European centers. Is there now any possibility of collecting this in a prospective fashion, or do you just say this is fine? Because you have a controversial statement, i.e., if you had muscle in the first one, there is no need for a RET-UR. Many people might disagree with that.
Yeah, I have to say something about the limitations of our study. First of all, we were not able to collect the indication for RET-UR. I mean that probably in our group of patients, there are some patients who received a RET-UR because the first UR was probably not complete, and this is for sure a bias. So the possibility to perform a prospective study, it will be a really great opportunity to understand the real role of RET-UR.
Paramariappan, Edinburgh. Interesting. I think it certainly confirms what we had shown previously, that the detrusor muscle is a good surrogate of recurrence and outcomes. I think just to answer Proka's question, on the back of QPIs and the work we have done, we've actually modified the QPI 4, which is on re-resection. We're now recommending no routine re-resection for all high-grade non-muscle invasive bladder cancer unless there is no muscle in the specimen. So that data is being collected at the moment. So hopefully we should have results by BAUS next year.
Any other questions from the floor? Okay. Francesca, thank you very much.
Thank you.
So congratulations again to Francesca, and just invite to the podium now Toby Page, and Toby is going to take us through the medical student and the BAUS Audit and Quality Improvement Award. So Toby, thank you.
Well, it gives me great pleasure to present the Medical Student Award first, particularly because actually the applications this year were up by 30%. So we had an absolute bumper application. Thank you to everyone who helped with the marking, but it gives me great pleasure to ask Sasha Moore to come up and collect his certificate. Sasha. Unfortunately, Dominic Hodgson can't be here to present the Audit Award, but we have an audit prize for CT Foundation trainees. There were two winning audits. The first one was George Hill, reducing antibiotics in trust biopsy. Is it sensible or is it dangerous? So if George could come up and collect his certificate, thank you. And finally, and not least, was Ricky Ellis from East Midlands Deanery with his audit on operative notes in urology, very topical at the moment. 3 cycles of looking at operative notes, so a lot of work done by him. Well done, Ricky.
Great, thank you, Toby, and congratulations to the various winners. So I'd like to invite Professor Dasgup to back up. We're keeping him fit this morning. Professor Bivalacqua and I had consensus on the winning paper, and Professor Dasgup will just award that now, so thank you.
Thank you so much. The BJUI International Prize for the best paper at BAUS goes to my favorite city, New York, of course. Sarah Howells. I had a small question for Sarah. Sarah, your abstract says 5 new loci. Your paper said 6 new loci in your Manhattan curve. Did the 6th one turn up last night?
Well, when we first looked at when we were doing the abstract, there was only one point that was over the GWAS significant threshold, so we weren't sure about including it, and then when we looked at our analysis, it does look like a screw, so that's why we provided that one away.
Congratulations.